A very good morning and welcome to the day 2 of 2-day conference on emerging challenges and advances in neurosciences. The speaker of fourth technical session of the international conference is Dr. Hassan Tawheed Sir. Dr. Hassan Tawheed Sir is MBBS, 2 times TEDx speaker, and presently holds the position of CEO and Director, California Institute of Behavioral Neurosciences and Psychology. His teaching experience includes personality development and has taught several research to the thousands of students in the previous 5 years. He has developed 30 plus short courses on research and career development, 3 comprehensive educational training programs for international medical graduates on research writing, SPSS data analysis, and meta-analysis. Research work of Sir has been as a visiting scholar at the Neurosciences at the Center for Mind and Brain, Neuroimaging and Electrophysiology Lab, University of California, UC Davis, Department of Neurology. In the clinical domain, Sir works on substance abuse counseling, clinical training internship in psychiatry at Napa State Hospital, Napa Valley, California. He is certified in addiction counseling by California Board, in neuro-linguistic program practitioner, and as life coach, child and adult trauma professional, and several others. Sir holds the professional membership and associations as a legislative ambassador at ECAN, member of American Neuropsychiatric Association, Leadership Council member of American Cancer Society, to name a few. Sir holds over 40 publications to his career, 2 books, 4 e-books, 6 book chapters, and the list is never ending. We are lucky and privileged to have you on this platform. Sir will be delivering his talk on neuroscience of demonic possession. The stage is all yours, sir. We at Amity Institute of Pharmacy, Amity University, Uttar Pradesh, Lucknow campus, welcome you once again. Sir, please.
Thank you, everyone. Thank you. Thank you, Amity University. Before I begin, I want to thank you for a wonderful introduction, but I just want to mention that there were few errors in the introduction that were not accurate anymore. They were not relevant anymore. I don't know how you got that information, but I'm glad you researched a lot about me. I'm no more associated with University of California and with American Cancer Society anymore. They were the past associations. So just wanted to give a quick correction because I just like to be 100% transparent. So that's it. And the rest of the things you mentioned, most of the things I guess were correct. So thank you. And today's topic is a very interesting topic, and I hope everyone is already here. The students will probably love this topic because this is very scientific, and we're talking about a controversial topic. Let me begin with the story. I delivered a TED Talk on the platform of TEDx, University of Alberta, Canada. The topic was the myth of demonic possession. My topic was actually demonic possession, a myth or reality. But for some reason, the TED team or somebody, I don't know who did it, they changed the topic to the myth of demonic possession. So that video is available on YouTube. And when that video was uploaded by TED, I got mixed reviews. Although most people appreciated, most people liked it, but there was a negative plethora of negative messages that I saw. And I was told by many of my students as well, and many people I know, that there are very aggressive comments out there. So some people got offended. So if you get offended today, that's why I'm here to answer the questions. I'm not here to offend anyone over here. I'm here to tell you that there is a scientific phenomena behind everything. There's a scientific process behind everything. I am not denying demonic possession. I don't want to hurt anyone's sentiments. But what I'm saying is that what we think is demonic possession actually is scientific. There is a scientific phenomena behind it. So let's begin. Let's begin this session, but I would like the moderator to give me permission to share my screen. Only the moderator can give me the permission to share my screen because I have a presentation ready for you.
You are already a panelist. You can share.
Thank you. I hope everyone can see my screen now.
Yes, sir. It is visible.
So this is the topic. I hope there are no spelling errors. That's what my hope is. Because I had a very short notice of creating this lecture, and I created these slides, the pictures and everything. I got it from Google, and I have given a reference. Nothing is there that is my property, so I just have to give a reference. That's the way we actually do work in the US. We must give a reference, and we must acknowledge where we got all the information from. So I have tried my level best to give all the acknowledgements. So that's my background. I have been associated with this field of neuroscience for so many years now, have written so many papers, and DID, dissociative identity disorder, and schizophrenia, and of course, the drug addiction have been my topics of research and study and profession. So let's talk about this. So this is neuroscience. This picture is also from somebody I have quoted later. We'll see that. Anyway, so what is neuroscience? We will begin from there. We need to see what actually is neuroscience. According to Wikipedia, that's a very good definition. Neuroscience is a scientific study of the nervous system. It is a multidisciplinary science that combines physiology, anatomy, molecular biology, developmental biology, cytology, computer science, and mathematical modeling to understand the fundamental and emergent properties of neurons, glia, or the glial cells, and neural circuits. So essentially, in easy words, everything related to human brain, anatomy, physiology, chemistry, cellular level, structural level, everything is included in neuroscience. So that's what is neuroscience. And we'll start with a story. I don't know if anyone knows who this girl is. This is Annalise Michel. She is very famous. She was born in 1952 in Germany, and she died in 1976, a little before her 24th birthday. So she was 23 years and almost 10 months when she passed away. So why is she famous? She is famous because she is considered to be the most famous demonic possession case in the world. It is believed that when she was in her teen ages, she developed the demonic possession. Some demons possessed her body, and that possession was so severe that nobody could treat her. Nobody could treat her. No doctor could treat her, and priests took over. They could not treat her either. So what actually happened? She grew up like a normal child. That's what we know so far. And her childhood was absolutely fine. She grew up in a religious family, a Catholic family. And by the age of mid-teens, probably 15, 16, she developed her first symptom of seizures. She developed seizures, and then her condition started to become worse and worse. She started to hear voices. She started to do certain things that not everyone does. For example, she was found eating insects. And by the way, this story was depicted in the movie.
Exorcist.
Not
Exorcist?
only Exorcist, not only Exorcist. Exorcist was the first one. That's correct. But the movie was Emily Rose, Exorcism
Okay.
of Emily Rose.
Yeah,
I did
yeah,
not remember the name, but now I do.
yeah.
Exorcism of Emily Rose, and all those sorts of movies, actually, they are inspired by her story. So what happened to her? Let's see. She changed her personality. She was possessed by Lucifer himself. Lucifer is the devil in the Christian religion, the biblical Satan, the biblical villain. And she also was possessed by 5 other personalities: Nero, the spirit of Nero, Hitler, and few other names she used to mention. She ate insects, and she began speaking different languages. She claimed she was possessed with demons, and later she died due to dehydration and malnutrition. So these were her symptoms. So what actually happened? Now you saw her face, a beautiful looking girl. This was the treatment phase, and this happened. This was the treatment time. When the treatment took place, she became aggressive, and possibly, as the pictures show, that she may have injured herself. She must have beaten herself if nobody else was beating her. That's what is reported. It is, if you see, these are very bad injuries. If you see the eyes, if you see the cheek, these are very bad injuries. She looked really possessed. They gave her the medications according to doctor's prescriptions, but the medications were not responding the way they should. That's why the family, naturally, if you have a family member who is being seen by doctors and is not improving, what do we all do? We go for spiritual help. It happens everywhere, right? So the same thing happened with them. They went for the spiritual help. They took her to the priest. They thought, multiple priests were involved. They thought that she needs exorcism. But in Catholic religion, you cannot do exorcism. The exorcism cannot be done without the church's approval. They sought church approval, and church believed that yes, it is demonic possession. So her treatment began, and she went through 67 rites of exorcisms. 67 before she passed away. This is a big number. And because she was not improving, parents were convinced, and the priest was convinced, that this is a demonic case. They stopped medical treatment. Now she was solely on spiritual treatment. Now this spiritual treatment continued, and they believed that they saw different things happening, like changing voices, speaking different languages. In the movie, they have shown supernatural phenomena like she had the energy of 4 or 5 people, and she used to levitate, or she used to do some things that not everyone can do, like closing the lights, turning on the lights and turning off the lights, closing the door, shutting the door off without physically touching it, with her eyes, with her hand gestures. That's what they have shown in the movie, but there is no actual evidence that this happened. But whatever happened, if you see the face, if you see the changing of voice in 1970s, remember, this is something we're talking about 50 years ago, 1970s. There's a huge difference in our knowledge now after 50 years. What we used to know in those days, we don't know this much. We did not know this much at that time, but we know a lot today, but it's still not sufficient enough. But what we do know is that there was something happening, and let's see what happened. So the strange symptoms that is unanimously agreed upon is her physical appearance, as you can see in the picture. Secondly, her changing of voices and speaking different languages. These were enough to convince somebody that this is a case of demonic possession. In those days, church gave the approval. And by the way, sometimes they can have some strange movements, dystonia or something like that, strange movements, and people feel that this is something unusual without any scientific explanation. So they diagnosed her as demonically possessed. Later on, when she passed away, unfortunately, at the age of 23 and 10 months, this case was taken to the court. The court believed that she was actually killed because of the negligence of her parents and the priest, because they stopped the medical treatment. Had they continued the medical treatment, she would have been fine. That's what the court believed, and they were sentenced. They lost the case. The parents and the priest lost the case. And this is the story of Annalise Michel. But later on, court gave them a probation, acquitted them, because the court also believed that this is too much for the parents. They have already lost their daughter, and because of their negligence, they have lost the daughter. Now it would be too much to put them in life imprisonment or something like that. So they were released, and Annalise is still a mystery. What actually happened, how it happened, why it happened, and she is remembered in the history now. So many books have been written on this topic, so many podcasts, so many videos, and TED Talk. My TED Talk was on this subject. So she has been covered in news so much, in books a lot, that almost everyone who knows about demonic possession at least knows her, if he is a serious student of demonic possession. On the contrary, scientific community also knows her. If you belong to psychiatry and you are interested in the neuroscience of demonic possession, then you know her as well. That's what we are going to talk about today. So what actually happened? Let me show you another picture. Look at this. This is the situation. That's how she looked like. She looked like when she passed away, unfortunately. And imagine the wonderful looking girl had to see this, and her family had to face this. And whenever I see this, it's so painful to see and watch that I immediately move it, because I don't want to get upset or sad. So this happened. So what happened actually? That's the question. Do we have a scientific answer to this question? Does science, medical science or neuroscience or psychology, any kind of science, have any kind of answer or explanation to her symptoms, to what she had? If we can give the answers to the questions scientifically, then it is not actually a demonic possession. It's a scientific problem. Probably it's a mental disorder, psychiatric disorder, neurological disorder. We don't know yet, right? In this conference, we don't know yet. That's what we will explore. So let's move forward. While many people consider it as a demonic possession, does psychiatry or psychology say something about demonic possession? Have we even seen anything related to demonic possession in the field of psychology? Has this word demonic possession been used? So the answer is, let's see what DSM says about demonic possession. Now, what is DSM? For all the non-psychiatry or psychology students, let me explain what DSM is. Diagnostic Statistical Manual, DSM, Diagnostic Statistical Manual. This is a manual in easy language for layman term. I would put it this way, that demonic possession has been defined as one of the problems by DSM. But what is DSM? DSM is a dictionary of mental illnesses. In easy words, you name a disease, you will find proper definition in DSM. And if a patient has the symptoms defined by DSM, then the patient fulfills the criteria of DSM, and then it can be officially diagnosed in the world, and now in the world actually as well, and not in just the US, in the world actually, not just the US. Although DSM is by American Psychiatric Association, and we have now 5 DSMs. This is the fifth version of DSM that was launched in, I would say, published in 2013, May, the month of May 18, 2013. Yes, 2013. That's when the DSM-5 was published with new definitions of various diseases, various problems. And DSM-5 does have dissociative identity disorder as one of the problems. And let's see what DSM-5 says. I have a mini definition of what DSM-5 says, but if you Google it or you purchase DSM-5, you will be able to read it. DSM-5 has also a pocket version. You can find it and you will read this definition. So there are 5 criteria, and we will look at the criterion number 1. So DSM defines DID, dissociative identity disorder. Everyone who is listening to me can take notes. Dissociative identity disorder. We also call it as multiple personality disorder. This was an old name. Some people also call it as split personality disorder. So DSM provides the following criteria to diagnose dissociative identity disorder: 2 or more distinct personalities or identities or personality states are present, each with its own relatively enduring pattern of perceiving, relating to, and thinking about the environment and self, which could be seen in other cultures as the experience of possession. Amnesia is a must requirement. This is a mini definition. You can go and get the full version of DSM. You will find descriptive definition. I have shown the slide in my TED talk with the full descriptive definition. You can watch that TED talk to get the full definition, because I could not find my own slides. Otherwise, I would have saved that for you guys with the correct full definition. This is a mini version of the definition. So just making this point clear, that's why you will find the discrepancies, the differences between this definition that you see on the screen and the main big DSM-5 book, because this is a mini book, the pocket books definition that I'm showing to you. And I have just added the line which says that which could be seen in other cultures as the experience of possession. So point number 2, amnesia must occur. That means they forget what happened. When they have the second personality over, they forget. Defined as gaps in the recall of everyday events, important personal information, and or traumatic events. Point number 3, the person must be distressed by the disorder. The person knows that there is a problem, but he doesn't know what is the problem. They know there is a problem. They are not happy with the problem, or have trouble functioning in one or more major life areas because of the disorder. Because they cannot work, they cannot study. If they are students, they cannot study, because if you have exam coming up, you have your personality taken over. How can you go and take an exam? Because you don't even believe you are the same person anymore. Same thing with the job. You cannot even do job. So their daily life is affected. And of course, their relationships are affected. Point number 4, the disturbance is not part of normal culture or religious practices. In some religions, in some cultural practices, some spiritual phenomena are done where you will be forced to change personality for a time being. Or if you have seen something like people playing religious music, and the listeners, they lose their personality. They don't know who they are. They are now just dancing. They forget everything. So that's why that kind of situation is not considered as DID. If it's a cultural or religious practice, if you are listening to a religious song and you forget who you are, then you are not a DID patient, because that doesn't happen to you all the time. That does happen once or twice when you were involved in listening to a religious music or something, or a cultural music or something. That's why they don't keep it in the criteria. These symptoms, point number 5, these symptoms cannot be due to direct physiological effects of a substance, such as blackouts or chaotic behavior during alcohol intoxication, or a general medical condition such as complex partial seizures. So if a person has taken a drug like alcohol, let's say alcohol, or any drug like cocaine or methamphetamine, and they have forgotten who they are under the influence of drug, so they cannot be called as DID patients. Because when the influence of the drug is gone, their personality comes back. So this is a condition. They should not be using drugs. Now, what actually happens? Let's say I'm this person here. If I'm demonically possessed, you feel that, okay, he has a demon who has taken over his body. Now I become a Lucifer, or I become some other person of any religious figure or something. So that will be a demonic possession for a layman. But in psychiatry, in medical terminology, in neuroscience, in psychology, we call it as dissociative identity disorder. Now, these personalities can be just 2 personalities, one normal personality that I identify myself with, and the second personality is a rare personality that comes sometimes. So let's say my first personality is Dr. Hassan Toeed, but if I have DID, my second personality would be something else, some unknown person, or maybe I consider myself as a known person, a famous actor or somebody unknown that nobody else knows. I say, okay, my name is Jonathan, and I live in California, and I am Jonathan, and I am 50-year-old, or I'm 70-year-old. I'll behave like that person. And when I come back to my face of Hassan, come back to my real personality, other people will tell me, do you know you lost your personality and you were Jonathan for 15 minutes? Or you were Jonathan for 1 hour? Do you know that? I would say, no, I don't know that. I don't even remember. People who have DID, they believe later that they have DID when somebody shows them their videos. That this is what happened to you. Let's talk about some famous cases. First of all, let's talk about the movies. There was a movie known as Split. A few years back, this movie came, Split, Hollywood movie. It talked about DID, dissociative identity disorder. This person changed his personality. Another movie was released in 1996 that was copied later by Bollywood. So that is also, I just don't remember the name of the movie. Let me search it for now for you guys right now, so that you guys who are interested can look at it. So this movie was of Harrison Ford's movie, 1996. I don't find the name. Okay, so once I find the name, I will send it to you guys. Okay, if I go to filmography, it's a long process. I don't want to waste time, but it's a Harrison Ford movie, 1996, that was later copied by Bollywood in 2002. And both movies were very good. Both movies were very good, and the actors performed really well. They performed a role of two personalities. Okay, so that's something you guys need to watch if you're interested, if you like it. Now, another Bollywood movie came around 2007. And I recommend to all of my students, even who cannot understand Hindi language, I always tell them to watch that movie with subtitles. That is about DID. And the movie is, it is called Bhool Bhulaiya. So you guys, if you're interested in studying DID and demonic possession, watch that movie, how that psychiatrist treated the patient of DID, who actually everyone thought had demonic possession. They thought she had spiritual issue. Actually, I will just take my words back. That was not Harrison Ford. That was Richard Gere in that movie. Okay, now I remember. That was Richard Gere. Okay, so just correction. Everyone who is interested in studying DID should watch that movie and the Indian movie. I don't remember the name of the Indian movie, and I will search it and I'll get back to you guys if anyone is interested. Or you guys just search DID movies, Hollywood movies.
Was it Primal Fear?
You got it.
Primal Fear by Richard Gere.
Primal Fear, yes, Richard Gere, Primal Fear, 1996. That's the name. That's the name.
So one of the Hindi movies, Aparichit, students would have seen. It's a Bollywood and even
okay. Okay.
Mm.
Okay, very good. And another movie was of a famous actor. The Primal Fear copy was by Ajay Devgan.
Kartik Calling. One of them was Kartik Calling also, which is about schizophrenia. Yeah.
Okay. I would love to see those. You know.
And another one, the best one of schizophrenia is Beautiful Mind.
Oh yeah, absolutely.
It's a global, I think, Academy Award winner.
Yeah, absolutely, absolutely. In this lecture, we will talk about schizophrenia as well. We're talking about DID right now, but we will also talk about schizophrenia because that is also confused with demonic possession. We will talk about that today. And the movie I was talking about was of Ajay Devgan, the actor, and that was yeah. So if you type Ajay Devgan DID movie, split personality movie, multiple personality movie, it will show up. And I was flabbergasted when I saw the acting. I was so impressed by this acting of this actor. So you guys should watch these movies. You will understand how DID patients behave. This is a very good educational phenomena you have now, is to watch movies so you can understand how these patients behave. So now the real cases, let's talk about the real cases. Case one, the famous case, these are discussed by scientists, covered in news, covered in articles and blogs. These are famous cases. So one woman had 3 personalities, age 5, age 17, and age 35. When the 5-year-old was examined, she had a condition common in childhood, that is lazy eye, in which one eye turns in towards the nose. One eye. The condition was not present in the 17-year-old and the 35-year-old. So when, let's say I am a person, I have 3 personalities. One of my personalities has a lazy eye, one eye goes inside. The other 2 personalities have a normal eye. How can a person do that? Can you imagine this? That's why people think it's a demonic possession. But the situation is, guys, the human mind is so powerful, it can do anything. It can do miracles. That's why it was very difficult to explain 50 years ago or 60 years ago, or even imagine 200 years ago, that it is not demonic possession, it is a mental disorder. Let me give you another example. The famous case of Timmy the patient. This was a patient. If you just type Timmy orange juice hives cases, just type it like this on Google, you will find it. So this person had 12 personalities, I guess 11 or 12 personalities. One of those personalities was called Timmy. So all personalities, they used to develop hives when they used to drink orange juice. But whenever he was Timmy, you give him orange juice as much as you like, he never developed hives. So this was not a demon. He was calling himself him Timmy, not a religious figure, not Lucifer. Normal person. Timmy was the healthy one. Now, there are cases. Case number 3, people, when they change personality, they can change their eye colors. Can you believe that? Nobody would believe that, but this is reality. This is reality. This suggests that eye color, although it's controlled by genes, but it can also be controlled by human brain. We need more research on that, how it happens. Now, another case, one of my favorite cases, is of a blind woman. She lost her vision at age 20. And by the age of 33 or 34, she started to get, during that time, she developed this DID with 16, 17 personalities. I don't remember exactly how many personalities she had, but during the psychotherapy sessions, one of her personalities, she was blind. Now she is switching from one personality to another, but one of the personalities started to see. Now, the psychiatrist probably thought that, okay, now her vision is back. But when she got to her other personality, she was blind again. So now the question was, is she faking blindness? Because if one personality can see, the other personalities cannot see, then definitely the chance is that this is a fake problem. They tested her on electrophysiological studies. And it was confirmed that it was not fake blindness, it was real blindness. I'm telling you all the real cases. This happens. Tony Robbins, famous motivational speaker. Everyone knows Tony Robbins if you belong to personal development, life coaching. Tony Robbins is in one of his books mentions a case of a DID patient that one of the personalities had diabetes, the other patient did not have diabetes. When the personality with diabetes took over, his blood sugar level goes up. When the other personality took over, the blood glucose goes down. This happens. So this is mentioned in his book. Probably he saw the case, or a psychiatrist he was dealing with for some reason was looking at the case. But this is the case mentioned by Tony Robbins in his book. And there are so many other cases. And Split movie has shown these kind of phenomena, the skin changes or those kind of changes. So these kind of strange things are possible. So if Annalise probably had moved her eyes like this, had changed her eye color, for example, although we don't know if she did, or was one of the personalities was blind, or one of the personalities had diabetes or any other problem or hives, that is scientifically explained. There are other cases who were non-religious in nature. They were non-religious in nature, and they had this kind of problem. They were not demonically possessed. They were with different personalities, non-religious personalities, right? They were non-religious characters that were taken over. Their body was taken over with. Now, the strange phenomena that we saw in Annalise's case was speaking multiple languages. How did she speak multiple languages? Many people have this question. And in my TED talk, I saw so many people commenting that, oh, he did not explain why she spoke different languages, why she spoke different languages, why she spoke different languages. There was no explanation. That's why I believe it was a demonic possession case. So I felt so bad that in my presentation, I forgot to mention that. I forgot to give an example that why she spoke different languages. First of all, if you see the movie, one of the movies that was about Annalise's case, one of her friends testified that she used to go, Annalise used to go to linguistic department and she was into languages. So possibly she was learning languages without anyone knowing. That's number one. Secondly, anyone can speak multiple languages. That's not a mumbo jumbo philosophy. In the US it is. In the US it is. They just speak English, right? Most of the time. So it's a mumbo jumbo philosophy for many of our US friends and colleagues that how people can speak multiple languages. I myself can speak, I don't know how many languages. I can speak English, of course, as you can see. I can speak Hindi, I can speak Urdu, I can speak Spanish, and I can speak a little bit of Arabic, and I can speak Chinese. 6 languages I can count, and Italian 7th, and few words of French. So 8 languages, although I'm fluent in only few of them, but I can speak a lot of words. So if you see Annalise, and if you hear her videos, her audio recordings, we have her audio recordings on YouTube. Please go after this lecture on YouTube and listen to audios. She is just repeating the same words again and again. Limited words, simple lines, not a complete conversation. So anyone can do that. Anyone can memorize certain lines and certain words of every language. I have never been to any Arab country, but I can speak Arabic. I can understand Arabic a little bit. And I have never been, no, I have been to China. Okay, I have been to China. So I can speak a little bit of Chinese. So I will change my words. Yes, I did go to China twice during travels. So, but the thing is that I do speak a little bit of Chinese. Ni hao, wa han hao, wa chao san, xin se chi tian, ni chao sama ming se. So there are so many words I'm seeing right now. I learned this because I love languages. Although I'm not fluent in Chinese, I will never tell anyone I know Chinese because I cannot speak in Chinese. But because I have loved languages, so I can speak certain words of certain languages. Like in French, I know how to say thank you, merci. bonjour, how to say hello. In Italian, I know how to say ciao, hello, como te va? Just like Spanish is quite similar to Spanish, and Spanish, I'm fluent in Spanish. Hola, hola, ¿cómo estás? Bien, gracias. Soy Dr. Santo y estoy aquí in su clase. See, I can speak Spanish, I can speak English, I can speak Urdu, Hindi. So that, does it mean that I am demonically possessed? Somebody who speaks only one language, who has never ever tried to learn any other language, for him, I am a miracle. But for many of our Indian friends, I'm not a miracle. See any Punjabi student, see any South Indian student, he will tell you how many languages he can understand. Talk to any person who is living at the border of Tamil Nadu and with other states, he will tell you he can speak Tamil, he can speak English, he can speak Hindi. And possibly if he has a Punjabi friend, he can speak Punjabi. So in terms of language, nobody can beat Indians. Indians speak more languages than anyone else. So does that mean that this is demonic possession? No. People don't know that in many countries like India, there's so many languages. One person can speak so many languages. Although he will not be fluent in all languages, but he will be able to speak so many languages up to some accent, maybe some lines, 1 line, 2 line, 3 lines. Same thing happened with Annalise. She was not speaking complete lines. She was speaking some words of Latin, some words of French, and German was her language. So you can go and listen to her audio and you will understand that she's just using some lines. Anyone can do, anyone can use lines of any language. If I get another personality, Mr. Wong, one day I become Chinese personality. If I get DID, I'll be speaking the same words and people say, oh, he speaks Chinese, although I will be repeating the same words again and again. But who doesn't know Chinese, anyone who does not know Chinese will think, oh, wow, he's fluent in Chinese suddenly. So he is demonically possessed. Now, another thing I want to mention, that's common sense we need to understand and analyze this way, that Annalise was Catholic, so she was possessed by Lucifer. Why was she not possessed by Yamraj? Why was she not possessed by Ravan? Because she was Catholic. Why was she not possessed by jinns? Because she was Catholic. She doesn't believe in jinn. Muslims believe in jinn. So when Muslims believe in jinn, you will see a Muslim DID patient who is religious in nature will be possessed by a jinn. So common in Muslim DID patients. So common. They think they are possessed by jinn. If it's a Christian person or a Catholic person, they would believe that it's Lucifer or a biblical figure. If it's a Hindu patient who is religious in nature, who he would find a character from Mahabharata or Puranas, any religious book. He would find that kind of character, a good character or a bad character. We don't know what happens in their mind. They can develop a good character or a bad character. There are DID patients who have like multiple personalities, but all the personalities are nice and friendly. So positive personalities can come over too. DID is the reality, and demonic possession, what people think is a demonic possession, it would have been a reality. I would have believed in it if everyone would have been possessed by Lucifer, or if everyone would have been possessed by one particular religious figure, then everyone in the world would have been following one religion only. Then people would say, okay, this religion is the reality. I'll believe in this religion because everyone gets possessed by this religion. But it never happens. People always get possessed by the religion they belong to, a personality from the religion they belong to. A Muslim patient does not get possessed by Yamraj. A Hindu patient does not get possessed by jinn. So just analyze this as a scientific. I have given you something to think about. As students of science, you guys can think about that. What I have said, does it make sense or not? Now, how does this happen? Causes and risk factors. Who develops DID? Remember, it's just 1 to 1.5% people. in the world who have DID. It's a very rare phenomenon. It's a very rare disease. Out of 100, you will see probably one person. And how it happens? Trauma. What trauma? Physical trauma? If you get your head hurt in a car accident, will you get it? No. We're talking about mental trauma, psychological trauma. Mental trauma in your childhood when you are a kid. If you are a kid and you have immense mental pressure, immense mental abuse, physical abuse, and sexual abuse, immense abuse again and again for prolonged periods of time, for so many years, they develop DID. Why does that happen? That's natural, because the mind wants to believe that no, this did not happen to me, this happened to somebody else. They change the personality. If they are religious in nature, they will get a religious character. Your mind needs something. If you are into movies, you will develop a movie character or a movie actor. So it's emotional trauma that causes DID. If you see any DID patient, just take a history and you will find out most of the time, 99.9% of the time, they have a psychological trauma history, mental trauma, emotional trauma, or parental neglect, that they were neglected by their parents. That's also a kind of trauma for a kid. Another cause is iatrogenic. This is just a theory, but we don't know. If it's iatrogenic, that means it's doctor induced, but we don't have any evidence on that so far. Not many studies that could verify it. So mainly it's trauma, psychological trauma. Now what happens? The mechanism. This is a quote from a study by Dr. Mitra and Dr. Jain. That's, I think, from a book. So this was in 2021, this year. So what they quoted by Dr. Putnam et al. And his team, they said the major hypothesis by Putnam et al. Is that alternate identities result from the inability of many traumatized children to develop a unified sense of self. See that? That is maintained across various behavioral states, particularly if the traumatic exposure first occurs before the age of 5. Now the next thing. Vermetin et al. Et al. Actually is a French word, I guess, or a Latin word. That means and his team. It actually means, when you see that in a research article, that means Vermetin and his team compared the female brain structure. And this is article, this line is actually from one of my papers, one of my scientific papers. Compared the female brain structure of DID patients with healthy subjects. The study demonstrated alterations in the limbic system, the hippocampus and amygdala of the DID patients were found to be remarkably smaller. So remember, the DID patients, if they are female especially, by the way, it is more common in females. This is very important to understand. This is more common in females, but that does not mean it is not in males. It is more common in females. And the size of the hippocampus and amygdala, that is the limbic system of your brain, is behind the ears. Okay, remember this. Behind the ears, we have limbic system. And limbic system is associated with memory and emotions. Amygdala controls the emotions and hippocampus controls the long-term memory. The size is reduced in these patients. They check their brain. How do they check it? Structural MRIs. They can verify the structure. And you can also see the dead bodies, the brain of dead patients, and you can see that the size of the hippocampus and amygdala was smaller. So if it is smaller, that means the problem is in the memory. That's why it is understandable why they forget when they change personality. Why do they forget the personality? That's the reason. Possibly that's the reason. And is it a coincidence that amygdala is involved? They have impulse control problem, anger problem, impulse control problem, emotional problem. Amygdala is reduced in size in those patients as well. Now another study. Dr. Elzinga et al. Studied working memory in 16 patients with DID or dissociative disorder, not otherwise specified. Dorsolateral, prefrontal, and parietal cortex regions were found to be activated in the patients, and the control group, same regions were involved in working memory. Okay, this is one case, but the thing is here, the controls also have the same thing. So we do have an idea, okay, there's an activation in the brain. But does this activation involve everyone? That's what we need to see. If we see the whole brain of every human being on earth, we will be able to see that if that happens. So, okay, that's not a strong evidence. Okay, now let's talk about, according to Sağır, Dr. Vedat Sağır is a Turkish psychiatrist and very well known, internationally renowned, and authority on DID. And I'm glad that I now know him and I'm working with him on a project these days. My book on DID is coming, and Dr. Sağır is with us. So it's an honor to have him. Now, what he mentioned was that cerebral blood flow in the DID patients was reduced in bilateral orbitofrontal cortex region. This part of the brain, the orbitofrontal cortex region of the brain had reduced blood flow. And this blood flow was increased in the median and superior frontal regions and occipital areas. And by the way, also another study shows that the temporal region, now this is parietal, so that's the temporal region. Parietal region, temporal region. So the parietal region and temporal region also has increased activity, increased blood flow. Okay, reduced functioning. So considering the decision making, okay, now let's talk about this. What this comment says. This is also from my study, by the way. So DID patients was reduced. This line from Dr. Sağır, I mentioned that in my paper. Regional cerebral blood flow in DID patients was reduced in the bilateral orbitofrontal cortex region, just like attention deficit disorder, and augmented in median and superior frontal regions and occipital areas. Occipital area behind as well, increased blood flow in DID patients in comparison to people who don't have DID. Sağır stated that the reduced functioning of orbitofrontal cortex leads in impulsivity. So because there is reduced functioning, because there is reduced blood flow, there is reduced functioning. So they have, remember now, frontal cortex. What does frontal cortex do? The decision making, the calculation, the cognitive abilities, and mainly the consequence center. This is consequence center of the brain. I call it a consequence center of the brain. That your prefrontal cortex tells you not to do bad things because there's a consequence behind it. So these people who don't have activity in that region or lesser blood activity, they are impulsive in nature. They will do certain things that they will put themselves in trouble with the law. They can hit somebody, they can attack somebody. That's why DID patients can attack other people if they have aggressive DID personality. That means they have reduced blood flow that's causing the impulsivity. And the expression of the new personality in DID could be a sign of impulsive behavior. The expression of new personality in DID could be a sign of impulsive behavior. See that? Cerebral blood flow has also been studied by other scientists. Okay, now let's move. Now this line, I got it from a blog by Dr. Monique, I don't know the full name. But it was I have given a reference here. You guys can go and check it out. It's a very good article, very, very informative article. Additionally, DID subjects showed, that's what she said, I've quoted her, showed larger signs of white matter that are conducive to communication between the somatosensory association areas such as basal ganglia and the precuneus. And she quoted Bilhar et al. See that? This is a recent research last year. Increased white matter. See that? We are still learning and we are still finding out that there are so many other changes that DID patients' brain have that other people don't. They have a different brain. That's why they are seeing these things. They are speaking these kind of languages and they are showing this kind of characteristics that we think is demonically possessed. This person is demonically possessed, but this person is not demonically possessed. There is a problem in the brain structure and function. Now look at this. This is very important. This is one of my favorite studies. This line is also, I think, from my paper. Animal models have shown that glutamate, although this is not my study, the glutamate is not my study, I quoted it in my paper. Animal models have shown that glutamate is released in the cortical limbic system during stress and may lead to neurotoxicity and behavioral changes with transient dissociation. So guys, see this, increased glutamate can cause DID, can cause dissociation in animals. We don't know if it happens in human beings yet or not. We don't know yet. We need more studies, and I'm giving you this topic to study in the future. If you want to do some research on this topic, the students, you guys are the students of pharmacology, pharmacy, you guys can do the research on glutamate. Maybe glutamate blockers can be a good treatment for DID. You guys can do it. Your research will tell us if glutamate blockers can be helpful, if glutamate blockers can actually improve the symptoms of DID. You guys may get a Nobel Prize or something. We don't know, but you guys can really do it. Nobody has tested it. It's just a suggestion that any drug that inhibits glutamate may improve the symptoms of DID. We don't know yet because nobody has done this study. Nobody has courage to do that so far. I hope any of the Indian students would be able to take this responsibility and see if glutamate blockers can really treat DID. Maybe if you have a hospital or a university IRB board, institutional review board, take permission and start research on this topic and see if it happens. If the review board allows you, nobody would, it needs courage to start a new drug treatment on a population. It needs courage. So that's why IRB boards are reluctant as well. But I'm giving you a topic for future to think about. A future topic to think about, can this be done in research? Now, so far, because we don't have any clinical trials on glutamate blockers, that's why the only treatment we have is psychotherapy. Long-term psychotherapy that can help probably, but how useful it is, will it permanently cure this or not, we don't know. No treatment, drug treatment available. Now, other problems that could be confused with demonic possession, yes, there are two. Schizophrenia and sleep paralysis. Of course, there are others too. Bipolar can also be confused. Any psychiatric illness can be confused with demonic possession, to be very honest, but I'm talking about two main big ones other than DID, schizophrenia and sleep paralysis. Now, what is schizophrenia? People call it schizophrenia, but it's actually schizophrenia, just like school. Schizophrenia. Schizophrenia has these three main symptoms: illusions, delusions, and hallucinations of all senses. Illusions, delusions, and hallucinations. So what is illusion? Illusion is when you see something and you think it is something else. That you are seeing a sofa and you think it's a lion. That's illusion. Delusion is a false belief, that you believe that this person is a lion. Or there is somebody who is living with you, but you don't know who it is. You think somebody is there. That's a delusion, false belief. Or the government wants to kill you, false belief. Hallucinations, all senses. They hear voices that do not exist. So people will say, oh, he hears voices, maybe he is demonically possessed. He is hearing the voices of demons. He hears voices very clearly, very clear voices. They can also have the tactile, the touch sensation, the hallucination. They feel that somebody has hit them, somebody has touched them. They feel somebody has beaten them up. They will sleeping and somebody beat them up. They will accuse you of beating. And then the olfactory senses, the smell, they smell things. They will accuse you possibly that you have mixed something in their food. If they accuse you that you have mixed poison in their food, that's actually delusion. But if they accuse that they can smell something and some terrible thing is mixed in their food, now that's the olfactory hallucination. So all senses, we have 5 senses, like, right? Sense of vision. So they also see things that you don't see. They will see the demons and they hear their voices, and you will say, okay, they are demonically possessed. But the reality is that they are not demonically possessed. They have just illusions and delusions and hallucinations. They are seeing people that you don't see. If any one of you has schizophrenia, just take help, take medication. We have medication treatment for schizophrenia. It improves the situation. You start to not see those things. You start to not hear those things. So remember, the hallucinations are of eyes, the vision, sense of touch, sense of smell, sense of taste. They taste something bad as well. And the hearing. They hear the voices. All senses super activated. Now, very few people know the difference between illusion, delusion, and hallucination. And these are very big words, right? So I tell you, I have a funny story. I have a joke for you guys today. By the way, these are the symptoms. These are the symptoms of schizophrenia. We have positive symptoms of delusion, hallucination, and disorganized speech. And we have negative symptoms, reduced speech, inhibition, and I don't know what was written here. It's so blurry. I got this picture from this website. Okay, but actually the negative effect can be anhedonia, apathy, all those kinds of things. Reduced speech, isolation, so many things, so many things. Now there's a joke. There is a joke, a story, a real story, a funny story, and a joke. When I was in my medical school, it was the 4th year. So 4th year, we had a community medicine subject. And in community medicine, we heard the word schizophrenia for the first time because we had the behavioral science topic there. So it was asked in the Viva. The question was asked, what is schizophrenia? Everyone memorized it. We all friends, we just got together and we planned that, okay, if the teacher asks you this question, what is schizophrenia? You say, the combination of illusions, delusions, and hallucinations is known as schizophrenia. Everyone memorized it. So I went there. I was the first one. And the teacher asked me, what is schizophrenia? I said, illusions, delusions, and hallucinations, schizophrenia. He said, very good. He said, okay, you are done. And I sat next to the next seat. My question was done. Now I went to another teacher. Now another student came. They asked the same question. The student replied, illusion, delusion, hallucination. And he was okay. He passed. The third student came, illusion, delusion, hallucination. He passed. Now the next, there was a girl. She also memorized the answer. She came and she said, the question was, what is schizophrenia? And she said, the combination of illusions, delusions, and hallucinations is schizophrenia. Now the teacher said, okay, define all 3. And she was like, huh? And we all were looking at it. We started laughing because none of us planned the definitions of illusion, delusion, and hallucination. So that's why I never forget these 3 things, because she was in serious trouble. So next time, if you have a question in your exam about schizophrenia, somebody asks you, always remember, the moment you say something, you are giving them a next question. So be prepared. Don't mention something that you don't know. Okay, now schizophrenia diagnosis by DSM. It's defined as a psychotic disorder characterized by disturbances in thinking, cognition, emotional responsiveness, and behavior. Schizophrenia falls under DSM chapter for schizophrenia spectrum and other psychotic disorder class. The DSM-5 outlines the following criteria. to make a diagnosis of schizophrenia. 2 or more of the following, at least for 1 month or longer period of time, at least one of them must be 1, 2, or 3. Delusion, hallucination. Now, illusion is not here. Disorganized speech. They have put disorganized speech, grossly disorganized, or catatonic behavior. Catatonia, you will learn later if you want to learn about it. It's like you get stuck. I cannot, we don't have time, you know, I want to finish it fast. I would explain catatonia. But remember, it's like you get stuck. You cannot move. That's catatonia. Okay. Now, negative symptoms such as diminished emotional expressions. Okay. Now, what other things can be there? Impairment in one of the major areas of functioning for a significant period of time since the onset of disturbance, work, interpersonal relationships, or self-care. Some signs of disorder must last for a continuous period of 6 months. The 6-month period must include at least one of the symptoms. See this complete definition so you can, we are running out of time, so you can later read about it. This video will be available on YouTube, so you can pause it here and read about it, or just go to DSM-5 and see DSM-5 schizophrenia definition, and you will see that. What is the criteria? Remember, the point is, again, the disturbance is not caused by the effects of a substance or a medical condition. Because some diseases, some problems, medical problems can also give you these kind of symptoms. For example, Lewy body dementia. You can have hallucinations. Okay. If there is a history of autism spectrum disorder or communication disorder childhood, the diagnosis of schizophrenia is only made if prominent delusion or hallucination along with other symptoms are present for at least 1 month. So these are the symptoms. Now, associated features, let's see, there's so many that it's very difficult to remember. All kinds of wrong things can happen. There are a number of symptoms that contribute to diagnostic schizophrenia, including inappropriate effect, laughing in the absence of a stimulus, unnecessarily laughing when you have nothing funny, disturbed sleep pattern, they have problem in sleeping, dysphoric mood, bad mood, depression, anxiety, or anger. As I said, apathy, they just have no happiness, just mute. Anxiety, not mute in terms of talking, but in terms of mood. Anxiety and phobia, then depersonalization, derealization. These are the detachment from the real self, from the depersonalization, this feeling of disconnect from their personality, and feeling that that surroundings aren't real. That's derealization. You feel that everything around me is not real. Difficult to explain because we haven't felt it, right? We haven't felt it, so it's difficult to explain. Cognitive deficits impacting language, processing, executive function, or memory, lack of insight into the disorder. They don't know if they have a problem. Social cognition deficit, hostility and aggression. Yes, cognitive impairments caused by the disorder may persist when other symptoms are in remission. This contributes to impairments in functioning and employment. Of course, who will hire a person who have this kind of issues? Interpersonal relationships and ability to engage in proper care. So that's why we have medication treatment and psychotherapy. That's how you treat them, medication treatment and psychotherapy together. So if any one of your family members or any of your friends or you have schizophrenia, the good news is it's treatable, it's manageable. Now, I would not say it's 100, it will go away 100%, no, but it's manageable, you can manage it. And there's problem in the brain, your ventricles in the brain, they grow in size, and you have the same problem, many of those just you saw in DID, that there is a problem in the occipital lobe, occipital lobe. I have my paper written on occipital lobe changes, structural changes, functional changes, chemical changes, parietal lobe changes, frontal lobe changes. Every part of the brain is affected in schizophrenia. And there are so many studies done. So there is no question about schizophrenia has mental problem or not, will brain be affected or not. There are so many studies to verify it. So that's why I did not mention what happens in the brain. You can imagine all parts of the brain are affected. All lobes are affected in schizophrenia. I have 2 studies myself, my review articles on occipital lobe and frontal lobe. Okay, now last that you can confuse with sleep paralysis, the most scary, the scariest. Sometimes, I don't know if you have felt it, when you are sleeping, you feel that you are possessed. Somebody is pressing your chest, somebody is pressing your neck. You cannot breathe, you cannot move, you want to move, you want to do something, but you cannot. And some demon is beating you, is standing on your chest or moving on your chest, pressing your chest, pressing your neck, and you feel you're going to die. You want to move, but you cannot. but you know there is somebody in the room. This is the most commonly confused problem with demonic possession. So what is exactly sleep paralysis? Sleep paralysis is a feeling of being conscious but unable to move. So when you sleep, you are conscious, so you are actually in REM sleep. It occurs when a person passes between the stages of wakefulness and sleep. During these transitions, you may be unable to move or speak for a few seconds, up to a few minutes. Some people may also feel pressure or a sense of choking. See that? Sleep paralysis may accompany other sleep disorders such as narcolepsy. Narcolepsy is an overpowering need to sleep caused by a problem with the brain's ability to regulate sleep. So it's a sleep disorder actually. Your regulation of sleep is affected, and that's how it feels. This diagram was at sleepcycle.com. The demon in your house, you feel like this, you're trapped, you cannot move. You can even see, you can see the roof, you can see the room, but you cannot move your eyes. You can only see one picture of your room. You can
Sorry
only
to
see the
interrupt
door.
you. If you don't mind, the speaker of the next session already, Dr. Shubha Shukla ma'am. She is scientist division of neuroscience and aging. So I request you to kindly wind up so that we can take couple of questions and answer the
That's
audience
it.
also.
That's the last thing. So this is the also demon in the house, and that's demonic possession. And remember, it's a sleep problem disorder, REM sleep issue. And you can read this later. Okay, these are the things you will see. And these are the references where I got this information from for you. And thank you. So we are done.
Okay, so,
Now, anyone has any question, I
yes,
can answer in the next 2 minutes.
Many questions have been posted. I'll take some relevant one. May I, if you allow? The first question comes from one of the participants, Sheetal Devlekar. She questions, are there any preventive measures to avoid DID?
Just good parenting. Preventing your kid from trauma, mental trauma, good parenting, no physical or mental abuse, happy life, healthy life, less stressful life. You can avoid DID.
Thank you, sir. Thank you for the answer. One more question we have from one of our graduating student, Ishani. She questions, can you please throw light upon shared psychosis?
Shared psychosis is a very controversial thing. Like multiple people in the family can have a same phenomena, if that's the shared psychosis, and they can have the same belief system. That's something. And the reality is, we are still studying. We don't know everything about it. One of the least understood phenomena, and this is something I need to study more. But yes, it does happen. It does happen. Multiple people will have the same psychosis, same false belief, same delusion. Whole family can have the same delusion that we are being seen by the government, we are being seen by the intelligence agency, we are seen by somebody. Whole family will believe, and they will have no logic, and they will be normal people like us, but they will have this one false belief.
Right. So thank you so much, sir. Thank you for your time and your wonderful deliberations.
Thank
Actually,
you. And now one last thing before I leave, that all the students who had some questions, who could not answer, or who want to stay in touch with me, I am on YouTube with my name. You can subscribe to my channel and we'll stay in touch. You guys can ask any questions out there. Anyone who could not get the answer, you can type the question on any of my videos. I'll get back to you.
Thank you so much, Dr. Hassan. It was extremely interesting session, and due to paucity of time, we are unable to take the questions. But I can foresee that the discussion would have gone for hours together, because this particular topic is creates a lot of interest, and you have very rightly tried to remove the cover on this topic, where everyone starts believing with a blind faith that it is out of supernatural things. And the way you have explained this phenomena in a scientific manner is something that is the great take home of this conference, I must say. So thank you so much for sharing your insights on this very important topic, which is always a burning topic for discussion. And in the given time, you have really touched upon extensively, starting from the case study and creating that interest and connecting with the audience through your examples and wonderful presentation. Thank you so much. And you have a standing invitation from us to visit our campus whenever you come to Lucknow.
Very soon. Thank you
Thank you
for
so
inviting me.
much. And it's a late night for you over there in US. And thank you so much for sparing your time and joining
Thank you,
us.
everyone. Thanks a lot.
Bye.
Thank you, sir.
Okay,
Thank
bye.
you.
Have a good day.
Dear participants, moving on to the technical session 5, we have with us Dr. Shubha Shukla ma'am.
Ms. Pranati, just sorry to interrupt. I would like to welcome Professor Dr. S.K. Kulkarni sir also, who has joined us for the session. Welcome, sir. We are so delighted to have you today also with us. Thank you so much for joining.
Thank you. My pleasure. But I'm a little late to join our discussions.
No, it's okay, sir. One more session to go. Very important session by Dr. Shubha Shukla.
Okay.
Yeah. Over to you, Pranati.
Thank you, ma'am. Welcome, sir. About Dr. Shubha Shukla, if I say she's a principal scientist and assistant professor at Division of Neuroscience and Aging Biology, CSIR CDRI. Ma'am is PhD in biochemistry and has been postdoctoral fellow at Wales Medical College of Cornell University, New York, USA. Dr. Shubha ma'am has over 21 years of research experience at Research Institute of CSIR, Central Drug Research Institute, Lucknow, and at Neurobiology Division at Defense Institute of Physiology and Allied Sciences in Delhi. To her credit, she has over 45 publications in journals of national and international repute. Ma'am has also been reviewer of several books published by renowned international publishers. Dr. Shubha Shukla ma'am has been conferred with Indira Gandhi Samman 2019 for commendable contribution to science by Shilek Foundation, UP. She is also recipient of CDRI Incentive Award 2019 for Best Publication in Biological Science by CSIR CDRI Government of India. Ma'am has been conferred with Jyotsnamai Raghunath Bhattacharya Award conferred by Indian Academy of Neuroscience at its annual conference in year 2005. She has received fellowships for her work media material for nanoscience in meetings in Washington and received Young Investigator Colloquium Travel Award for Society of Neurosciences. She is a member of Society of Neuroscience, New York Academy of Sciences, International Society for Neurochemistry, International Neurotoxicological Association, to name a few. Ma'am has also received grants worth several crores for various projects implemented under her guidance. Her deliberations will be on mechanistic understanding of neurodegeneration and regeneration in brain diseases. We, from Amity Institute of Pharmacy, Amity University, Uttar Pradesh, Lucknow campus, welcome you, ma'am. Over to you.
Hearty welcome, Dr. Shubha, from all the Amity fraternity. We are privileged to have you with us on this platform, and we have tried our level best to have a cross section of multidisciplinary researchers in the area of neuroscience. And your talk is definitely going to be icing on the cake. I am very sure. Over to you.
Ma'am, kindly unmute yourself.
Thank you, Professor Sunila and Ms. Praniti and Dr. Lucy for the kind introduction. and for coordinating my talk today, and also to Dr. Rahul Maurya, like he called me many times for the smooth coordination of this session. So just an introduction about what we are doing at CDRI. So most of the people in Lucknow would be definitely knowing about CSIR CDRI, which is one of the 4 labs of Council of Scientific and Industrial Research. And out of the 4 labs, CDRI is involved in drug discovery and development. And initially, like this Neuroscience and Aging Biology Division was established in 2019 by the current director, Professor Tapas Kundu. Initially, we were part of the Pharmacology Division. So our division is mostly looking into the different aspects of neuroscience, aging, and my lab is working on mechanistic understanding of neurodegeneration and degeneration in brain diseases. So,
Sorry to interrupt, Dr. Shubha. May I request you to please adjust your camera slightly? We are unable to see you properly. Slight adjustment of the camera, please. Yeah, now it's better. Thank you.
I'm so sorry for that.
No, it's okay. It's okay. Thank you.
So, my lab is involved in 3 different research activities. The first is the basic part in neuroscience, where we are dealing with the delineating the molecular mechanism of neurodegeneration and neurogenesis in animal models. Apart from the basic studies, we are also involved in the drug development portion, which is the mandate of CDRI. So here, the first we are doing the regulatory safety pharmacology studies, particularly the CNS studies. Then we have a very big chemistry division who actually synthesize different compounds. Those are synthetic compounds and phytopharmaceutical extracts as well. So we are screening those compounds for CNS activity in these animal models that we establish for our basic studies. So I'll start with something about what is neurodegeneration. Neurodegeneration, as most of you would know, it is the progressive loss of structure or function of neurons, including the death of neurons. Neurodegeneration it occurs in neurotraumatic, neurodegenerative, and neuropsychiatric diseases, and most of which have a chronically disabling nature and a complex multifactorial process. As you all know, the global population is increasingly becoming older, so is the prevalence of neurodegenerative disorders that impairs memory, cognition, and a person's ability to move, speak, and breathe. So about 14% of the global burden of disease has been attributed to neurodegenerative disorders. And WHO has predicted that by 2040, neurodegenerative disorders will overtake cancer to become the second most leading cause of death after cardiovascular disorders. So there's an urgent need for biomarkers that can diagnose disease long before neurological symptoms emerge, and to identify for drugs that might halt or slow neurodegeneration. So neurodegeneration is basically it affects either affects the motor functions of a person, or it affects the cognitive or the learning and memory. So motor symptoms are affected in four type of neurodegenerative disorders: Parkinson's disease, Huntington's disease, multiple sclerosis, and amyotrophic lateral sclerosis. Similarly, in cognitive impairment is seen in AD, that is Alzheimer's disease, Huntington's disease, and in Parkinson's disease as well. So what are the pathological hallmark of neurodegeneration? Neurodegeneration, actually, most of the cases are sporadic, that is, the cause is not known, and 95% of the cases fall under this category. Remaining 5% cases fall in the familial category, in which there is a genetic reason involved for the progression of the disease. So for the sporadic cases, the most factors that are known to be responsible for causing this type of neurodegeneration are protein aggregation of alpha-synuclein, A beta, and tau, and oxidative stress, inflammation, excitotoxicity, mitochondrial dysfunction, and altered neurogenesis and epigenetics. So the risk factors that are involved in neurodegeneration are, one of the most important risk factor is aging, which is known to lead to Parkinson's disease and Alzheimer's disease. Then stress is also an important factor that leads to neurodegeneration. Apart from this, environmental factors such as accumulation of heavy metals like aluminum, manganese, iron, zinc, then exposure to pesticides, then endocrine dysfunction like hypothyroidism has been known to lead to memory dysfunction and altered neurogenesis. Then alcoholism and drug addiction is another important cause that leads to neurodegeneration. Apart from this, microbial infections such as infection with HIV virus, HSV virus, and Japanese encephalitis virus has been known to cause neurodegeneration. Then what are the different targets that we are studying at CDRI are ubiquitin proteasome system in rat model of Parkinson's disease. One of the faculty in our division, she's studying this system in PD. Then one of another faculty, he's working on circular RNA in C. elegans model of Alzheimer's and Parkinson's disease. Then my lab is working on adult neurogenesis. Then we are collaborating with one of our faculty in microbiology department, where we have seen that infection with a Microbacterium fortuitum strain has led to neurodegeneration in mice. Then another faculty is working on proteasome inhibition in rat stroke model. And then we are also, one of our faculty is also seeing at the kappa opioid receptor for treatment resistant depression. So the things that my lab is looking in neurodegeneration is adult neurogenesis in rat model of Parkinson's disease, then protein aggregation in rat model of Alzheimer's disease, and chronic stress induced alterations in rat brain. So the targets that we are targeting adult neurogenesis. So neurogenesis, this is a process of generating new functional neurons from neural precursor cells and their integration into existing neural circuitry. Then this adult neurogenesis is spatially restricted to two specific neurogenic brain regions, the SZZ region, that is the dentate gyrus of the hippocampus, and the SVZ region in the lateral ventricles. So as you can see here, the stem cells, they actually originate from the SVZ region in the hippocampus. From there, they migrate through the rostral migratory stream, and then they migrate to the olfactory bulb, where they integrate with the existing neural circuitry. So altered neurogenesis, the neurogenesis steps are proliferation of neural stem cells, migration to the different targets, differentiation to neuronal or glial cell types, and then neurotransmission. So altered neurogenesis is implicated in attention deficit disorders, autism, mental retardation, low IQ, and then the neurodegenerative disorders that I mentioned before. So what are the different, different pathways that are that regulates actually the neurogenesis? So these are the three pathways that regulate the neurogenesis process. The first one is the Wnt beta catenin pathway. The second is the TGF beta SMAD pathway, and the Notch pathway. So presently we are targeting the Wnt beta-catenin pathway using different modulators like commercially available modulators and using shRNA mediated silencing also. So this is the first activity that we did where we used the shRNA of exin-2, which is the central regulator of the Wnt beta-catenin pathway. So what we see that what we observed that genetic knockdown of exin-2 upregulated this pathway, which led to improved signaling and improved behavioral functions in 6-hydroxydopamine induced rat model of Parkinson's disease by activation of neurogenesis in rats. Then the second work was we again targeted this Wnt beta-catenin pathway using the commercially available modulator of this pathway. So the GSK3 beta is the negative regulator of Wnt beta-catenin pathway. So we actually we use the inhibitor of this pathway that is known as SB. It is commercially available, and we inhibited this GSK3 beta, which resulted in improved neurogenesis and gliogenesis and improved behavioral functions as well. Then what we saw in subsequent studies that this pathway was communicating with dopamine receptor signaling also. So then we tried to, we looked into different literature and we saw that the non-motor symptoms of Parkinson's disease, they are regulated by the dopamine 1 D1 class receptor. So what we saw, we used different modulators of D1 and D2 pathway, D1 and D2 receptor, sorry. So what we observed that pharmacological activation of D1 receptor improved adult hippocampal neurogenesis, and it improved the non-motor symptoms in Parkinson's rat. And this was mediated through the Wnt beta-catenin pathway only. Then the second activity that we are focusing on is the STZ model of Alzheimer's disease. And here what we see, we are collaborating with one of member in INST, that is a DST Institute in Mohali. So there, Dr. Jeevan Jyoti, she is synthesizing nanoparticles, and we collaborated with their lab, and because what they saw in vitro studies that these nanoparticles were inhibiting A beta aggregation. So she discussed with us, and she wanted to see if the same phenomenon is happening in the animal model as well. So we tested in our STZ model these NTP nanoparticles, and what we see that these are actually fluorescent particles, and they inhibited the aggregation of the amyloid beta in rat model also, and improved memory, as you can see from the track plot. Then the third activity that we are working on is the effect of chronic stress, psychological stress on hippocampal neurogenesis. So stress, as we all know, due to the continuous exposure of animals or human beings, there is the activation of the hypothalamus pituitary axis, where adrenaline and non-adrenaline is increased, and cortisol levels are increased, due to which increased oxidative stress, glial activation, neuroinflammation, epigenetic changes are observed, which finally leads to decreased adult neurogenesis. So here we use the chronic unpredictable stress model in rats, where different stressors are given to animals, and the animals don't know the stress paradigm before. So in this, we gave the stress protocol for 21 days, and what we observed that the anxiety parameters were increased in these animals, and you can see from the light and dark test. So anxiety parameters were increased, then the force swim test also. The depressive behavior was increased in the animals. Then they were not socially interacting with the other animals. Then as you can see, when the stress is, the animals are exposed to stress because of the activation of the HPA axis, the adrenal gland weight is increased, hypertrophy is there. So here we observed that adrenal gland weight was increased, and subsequently serum corticosterone levels were also estimated, and we saw that the corticosterone levels were upregulated in these animals. So we concluded that chronic unpredictable stress, it promotes anxious and depressive behavior, and it upregulates apoptosis and inflammatory signals in adult rats. Then this is the another activity which I told you before, that we were collaborating with one of our faculty in the microbiology division, where they were using one of the strain of mycobacterium, which this is the M42 strain. So what they observed, that when they were infecting the animals with this strain of mycobacterium, the animal were showing symptoms which were like the symptoms that are seen in movement disorders, or particularly in Parkinson's disorders. So they were like they were tilting, and then when they were held with the tail, they used to spin. So they discussed with us, and then they took out the brain also. So to see if the infection is there, if the infection is going to the brain, because they were giving the infection from the IV route, and as you can see here, the infection was going to the brain, and it was going into the same area which is controlling the motor phenomena of the animals. So then they did the Zeal Nelson staining also for confirming the infection of the infrotitum in the brain. And then we did the locomotor activity and the imaging of the expression of tyrosine hydroxylase, which is a rate limiting enzyme in the dopamine biosynthesis pathway. And here you can see the locomotor activity was decreased in these animals after infection for 28 days. It actually, the effect was seen starting from day 10, and it became more significant on day 28. Then we did the quantification of dopamine neurotransmitter also in the brain, and it was reduced significantly in those animals. Then we did the rotarod study to see the latency to fall. And here also you can see the latency to fall was also seen from day 10 till day 28, confirming the neuromuscular incoordination in these mice. Sorry. So in this study, we saw that this strain is capable of breaching the blood-brain barrier, and it triggers profound inflammatory response in these mice. And the symptoms observed post-infection are neurological in origin, and this infection triggers reduction in level of dopamine. This is the regulatory pharmacology part that we are doing here. So we are actually doing the safety pharmacology CNS study. So most of the pharmacology students who have the background of pharmacology, they might be knowing the safety pharmacology are those studies that investigate the potential undesirable pharmacodynamic effect of a substance on physiological function in relation to exposure in the therapeutic range, or as per ICH guidelines. So the safety pharmacology studies are required to be completed prior to human exposure, following regulatory guidelines provided in ICH S7A for CNS studies particularly. So this safety pharmacology term was first appeared in ICH guidelines under topic timing of non-clinical safety studies in the conduct of human clinical trial for pharmaceuticals. So as we all know, there are different regulatory authorities which actually regulate the different clinical trials. So we know that in India, DCGI actually regulates all the clinical trial. Apart from this, CDSCO, SDCO are the state level controlling organizations. Apart from this, international organizations are also there, like OECD, ICH, WHO, and FDA. So what are the objectives of the safety pharmacology study? To protect phase 1 clinical trial volunteers from acute adverse effect, to protect patients, including patients participating in phase 2 and phase 3 trials, to minimize risk of failure during drug development, and to investigate the mechanism of adverse pharmacodynamic effects. So this is the core battery studies which are done in safety pharmacology studies. The adverse effect of any drug uh, in trial is seen on different systems such as central nervous system, respiratory system, and cardiovascular system. So my lab is focusing on observing the effect on central nervous system. So these are the core battery tests which are done to see the CNS effects. First is the gross behavioral changes, second is locomotor activity, third is neuromuscular coordination, fourth is body temperature, and fifth is sensory motor reflex response. So if any adverse effect is observed in the first phase, then we go to follow-up studies, which include observing learning and memory deficits, neurochemistry, ligand-specific binding, and visual and auditory examination. So the functional observation battery is done in rats, where we see the changes in autonomic system, neuromuscular system, sensory motor system, and behavioral responses. So this is done in rat. However, in the modified Erwin test, it is done in mouse, where the same autonomic and neuromuscular, sensory motor, and behavioral parameters are studied using these below mentioned factors. So then here we assess the locomotor activity by using the animal activity meter. So most of the MPharm students might be knowing about the locomotor activity assessment. This is done to measure the locomotor activity in specially designed cages that project infrared beam from one side of the cage to the other. Each time an animal moves around the cage, it breaks the beam and number of duration is recorded by the computer. The second assessment is done for the neuromuscular coordination, which is done by rotor rod system, which consists of a circular rod rotating at a constant or increasing speed. And animals are placed on the rod, and if they try to remain on it, or rather they try to remain on it and rather than fall onto a platform just below where the sensor is there, which actually senses when the animal falls, and the time is noted on the computer. Then body temperature is assessed using this body temperature multiplexer, where the mouse is usually hand restrained and placed on a horizontal surface, example a cage lid. The tail is then lifted and a rectal probe is gently inserted into the rectum to a fixed depth, which then actually records the body temperature of the animal. Then sensory motor reflex response are done using hot plate, and most of the students might have seen this hot plate. It is used to measure the pain or the nociception response in animals, and it is recorded by observing the jumping and hind paw licking elicited following a noxious thermal stimulus. So our facility, the safety pharmacology facility, is the first government approved government facility which is approved by NGCMA and DST, and it was approved initially in 2017 for 3 years, and again the validity has been increased till 2023, and we are authorized to do safety pharmacology studies, rodent toxicity studies, and pharmacokinetic studies. Then this is the screening part that my lab is doing. So as I told you before, the chemistry division in CDRI is synthesizing different compounds, and we are screening those compounds for in vivo antidepressant activity by force swim test and tail swim test, and in vitro protein aggregation inhibition assay against A beta aggregation and alpha synuclein aggregation. Then in vivo anti-stress activity. Then these are the projects that are recently approved and we are working upon. These are the latest schemes that are approved for our division, Neuroscience and Aging Biology, where we are working on the development of phytopharmaceutical for Parkinson's disease from aqueous calamus extract, unraveling cognitive impairments due to aging and neurodegeneration. Both these programs are sponsored by CSIR and novel and integrative approaches towards discovery of small molecule therapeutics for healthy aging. Then this is the basic science project, which is approved by a non-profitable charitable trust, where we are looking into the neuroprotective effect of carbon manosphere conjugated HACT activator and doing its preclinical toxicity testing and safety evaluation. This is also another project where we are looking into different ligands for treatment-resistant depression, and this project is also approved by CSIR. So in the end, I would like to acknowledge the funding agency, CSIR, DST, DBT, and my collaborators who are working with me, and my students, and I would like to thank all the audience for attending and for listening to my talk. And thank you so much for your kind attention. And I'm glad to take any question if you have. Thank you so much.
Hello.
Hello.
Yeah, Pranati, are you there?
Ma'am, I think she is facing some technical glitch.
Who? Pranati?
Yes, ma'am. Pranati?
Okay, fine. Thank you so much,
Yes, ma'am.
Dr.
Sorry,
Subha.
ma'am. My Zoom was not literally responding. It's giving me some.
Are you there? Or shall
Yes,
I?
Yes,
Are you going to continue?
yes, ma'am. Yes, ma'am.
Okay, please.
Sorry for the inconvenience. Thank you so much, ma'am, for that informative session. I could hear, but I could not unmute and switch on my video. So we have some couple of questions. If you allow, should we take it, please?
Yes, sure.
Now we have one of the questions from Dr. Jitendra Kumar Sinha, sir. He questions, what is your take on the point of convergence of neurodegeneration and neuroregeneration?
So what happens in most of the neurodegenerative disorders is there is a point of convergence where neurodegeneration actually starts, and neuroregeneration, it stops. I mean, not completely stop, but the process is slowed down at a certain age. the process of neuroregeneration stops and the degenerative process, they increase. They try to take over the regenerative process, just like the oxidative stress, inflammation. As we age, these processes, they start increasing, and yeah, that is my observation.
So that was one of the questions, ma'am. Then I suppose we have most of the participants have actually thanked you for the informative presentation. And yes, ma'am, Jiten sir, conveys thank you for the session. I would request anyone to, if wants to, can question up.
Pranati ma'am, if you will allow me,
Sure,
like-
ma'am, please go ahead.
may I go ahead with my queries, ma'am, with due permission, from ma'am as well.
Yes, Lucy, ma'am, you may go
Yeah.
first.
First of all, I'll thank you, ma'am, for this nice informative session. And as I do belong from pharmacology itself, so I have got some couple of questions. I mean some doubts as well. So I just need to put forward those questions to you, ma'am. The first thing I want to know is that, like, is neurodegeneration being possible at any of the human ages? I mean, because like from the beginning, that what the concept that we used to have is that neurogeneration, it is like the neuron cells, they do not, multiply in number. So if like some certain neuronal cells are being damaged, then like at what ages is there any chances, real chances of the neurons to get back?
Yes, Dr. Lucy, yeah, earlier it was the concept that neurodegeneration starts from certain age, say 60 years or beyond. People used to say that after 60 years only neurodegeneration starts. And this was also a very finite, definitive concept that the neurons, once they die, they don't regenerate. And we have a fixed number of neurons inside our CNS system, and we don't actually regenerate those dead neurons. But now, there are no stem cells in CNS. Something that this was the concept previously, but now people have discovered that neural stem cells, they do exist in central nervous system, and they do proliferate and migrate to the area of injuries, say in stroke or neurodegenerative disorders. And neurodegenerative disorder, apart from the aging, other factors also they contribute. Like you might have seen my slide where I've shown the risk factors of neurodegeneration. So like exposure to heavy metals, exposure to pesticides, then the endocrine dysfunctions like hypothyroidism or hyperthyroidism, they have been linked to results in neurodegeneration. And this type of neurodegeneration, it starts much early, before 60 years. Then exposure to different viruses, say Japanese encephalitis virus, hepatitis, HSV virus, then HIV virus. So these viruses exposure, and you might have seen one of my study where we have seen that one of the strain of Mycobacterium tuberculosis also has shown symptoms which are more similar to neurodegeneration as seen in case of Parkinson's disease. So these are the risk factors which actually results in neurodegeneration much early. What we used to believe that it actually starts at 60.
Then one more question, like if you are working on some phytochemicals or phytoconstituents, then means I would like for your suggestion, like whether it is good to target neurodegenerative diseases of the central nervous system or the peripheral nervous system. I mean, where they work good. Like we have got some like trigeminal neuralgia. So there you find the involvement of the peripheral neurons and all. So means where we can target them or where we can get better results.
So if you go into the our Ayurvedic ancient Ayurvedic literature, traditional knowledge system, if you go through that, you will see that there are certain plant extracts that have been mentioned in the that they are known as Medha Rasayans. So Medha Rasayans, Medha means your cognition. Medha is your cognition. So those rasayans are mentioned in our ancient literature, in our Ayurvedic system, and they have been shown to increase cognition, learning, and memory. So right now, a lot of studies are being done using those plant, like lot of plants are mentioned in Medha Rasayan system. So people are doing a lot of studies are now being done. We also have one such study which is funded by CSIR, where we are looking into the like what neuroprotective efficacy they are going to have on Parkinson's disease, Alzheimer's disease, stroke. So like we are presently one of the faculty, he is working on the efficacy of Withania extract in stroke, then Acorus calamus in Parkinson's disease, then Becoside extract. You might have heard about CDRI Becoside. It has shown a lot of nice activity in learning and cognition and memory. Even this extract, Besiv extract, is being used internationally also to increase cognition, learning, and memory.
Ma'am, one more question. Like recently, I could find that most of many of the activities are being carried out on the iron induced neurodegeneration. Means like this is the heavy metal right now we are considering. Ma'am, can you just focus on the basics, like what could be the predominant targets that we can basically target for while we are preferring this particular model, like iron induced neurodegeneration?
Yeah, iron has shown a very important role in inducing neurodegeneration, because in the substantia nigra region also there is a lot of accumulation of iron. So it has been shown to lead to more of oxidative stress, and which actually results in the depletion of dopamine. So in Parkinson's disease also accumulation of iron is implicated. And yeah, a lot of people are doing heavy metal induced model, and iron is one of them. I've seen many studies using zinc accumulation, iron accumulation, and aluminum accumulation. A lot of you might have seen studies using aluminum accumulation that leads to learning and memory deficits. So that's why now the concept has come that people should avoid using aluminum pressure cookers and using aluminum foils, because that actually leaches into your food and goes through your diet to your CNS, and degrades your memory actually. So the
But
same.
if that is the case, then there is also, propagation of going back to the iron utensils for cooking, uh, which we used to do earlier before the steel came. So if aluminum is harmful and you are saying that iron is also getting accumulated, so my question is then iron will also, over accumulation of iron, if we are talking about, do we say that we don't have to cook in iron utensils also?
Cannot say that, because yeah, definitely our ancestors, they used to use lot of iron based utensils. Even now also for making chapati,
Yeah.
we are using iron utensils only. But there have been actually a lot of studies where is particularly in relation to Parkinson's disease, where they
Mhm.
have seen that the increased accumulation of iron was seen in the brain area, which is responsible for Parkinson's disease. So that's why people started using this model, the
Mhm.
iron use neurodegeneration. But
Yeah.
I don't know how how much is it is I mean, I cannot comment on the iron thing.
You know, because this thing, the moment you said, there are few questions that immediately popped up in my head, that whether the anemic patients then are less susceptible to dementia and Alzheimer's, if that, or Parkinson for that matter. The second thing is, we say that, you know, iron supplements, hardly anything gets absorbed, most of it is eliminated. Third thing is, natural supplements of iron, if we are taking, they get absorbed well in our body. So
That's what
are they going to cause the accumulation of iron? So lot many questions suddenly, you know, popped up because of this particular question from Dr. Lucy and your response to it.
right. Yeah, actually, just like anything which is in excess, it would be harmful. Same would be the case for any heavy metals as well. But because, like as I told before, also that our ancestors were using iron a lot for
Yeah.
doing cooking and all. So I'm not sure about the iron concept. Yeah, I do agree with the aluminum concept that
Yeah.
it is leaching and it is causing memory problems and pesticides also, then hypothyroidism also.
Maybe in very, very less amount they are able to do this, I think so. Like
Right.
very, very nano quantities or ppm quantities, they must be able to induce this kind of effect with respect to aluminium. And maybe with respect to iron, it might be the concentration required to produce this effect might be slightly higher. Uh, that is my, you know, thinking about this.
Yeah, definitely.
Ma'am, can we take one more question from our BPharm first year student?
Yeah, we can
Abhinand.
definitely take, there are few questions from the students, definitely take them.
Ma'am, he questions, are there any genetic process to identify neurodegenerative diseases of newborns and so that it can be cured or treated earlier and in an easier way?
Yes, definitely many genetic tests are available postnatally and prenatally as well. So where the detection of any abnormality, any CNS abnormality can be done at an early stage. But the thing is that only detection can be done. There is no treatment actually available. A lot of studies are being done, gene therapy and all those things, but I don't know how successful they are. I mean, definitely detection can be done that some CNS abnormality is there. So if it is done prenatally, then definitely you can go for abortion or something like that. But after the birth has taken place, there is no treatment available for most of the diseases.
Is there a stem cell therapy available for Alzheimer's?
Yeah, people are doing a lot of stem cell therapies, but none of them is like shown to be fully working and approved by FDA as well.
Okay.
The stem cell is the most hot topic. Everyone is doing stem cell therapy in every disease, but
Mhm.
we are not seeing much success in that.
Yeah, and since we are talking about the effect, I mean, with aging, the neurodegeneration happens. Even if other precipitating factors are not there, age is one of the important aspects where naturally also the neurodegeneration speeds up. So we have read a lot of literature. What is your recommendation for halting the progression? I mean, if we are starting neurodegeneration in 60, probably can we do some nutritional supplements from the very young age where we can halt it or we can slow down the progression of the neurodegeneration?
Yes, definitely. Diet has a very important role in protecting us against the environmental factors and protecting us against different. Because definitely, if your diet is not complete, if you're more dependent on junk food or something similar, because students and youngsters, they are more happy with the junk food these days available. So what I would recommend that the vegetables which are available in your area, especially what I
Local.
feel, I have discussed with many clinicians as well that fruits or vegetables which are available in your area
Right.
help you most. If, for
Mm.
example, say I am in Lucknow and I am eating kiwi, kiwi will not help me.
Benefit. Yeah.
Kiwi is good for New Zealand people only.
Right.
And so similarly, the fruits and vegetables which are growing in my area will be most helpful for me. They will protect
Very
me.
rightly said. Yes. Yes.
So they will, and we should try to eat the fruits or vegetable which are available in particular season. Say, should not consume mangoes in winters
Mm.
or watermelon in winters, something like that. So we should try to avoid more and more of infections, any type of viral infections, such as I told you before, HSV or HIV infection, Japanese
Mhm.
encephalitis. Because if a child is infected with Japanese encephalitis at an early stage, he might definitely face more cognitive issues in the later part of his or her age. So parents, they should try to uh, stop the infections, the viral infection. Then another very important factor which one of the clinician in KGMC he discussed with me. He actually wanted us to establish that model also in CTRI, that he what they observed that most of the cases, especially the childhood cases of CNS infection they are facing are the neurocystic cirrhosis infection
Mhm.
that actually goes to the CNS, and then it leads to many other problems, motor problems, cognitive problems. So that is mostly because of the hygiene issues. The kids are not washing their hands, especially the small kids, school going kids, they are not properly washing their hands. So these larvae, these eggs, they go with the infected diet or with their hands, and then it reaches to the brain. And so these are the factors that we can control. The diet we can control, the infections we can control. Say somebody's some lady, mostly the women, they these days most of the women they face thyroid issues. So if somebody is having thyroid hypoia or hyperthyroidism, so she or he, I mean, it can happen in male as well. So they should regularly take their medicine and should not stop or try to avoid those medicines, because thyroid problem is a big factor for leading to memory issues
Right.
and
Right.
depression, then anxiety, like all of those bad things.
Yeah, very important message that you have given, Dr. Shubha, to our youngsters. So my question I had asked on their behalf only, because when it comes directly from the horse's mouth, they understand better. And so, dear students, what is local and what is seasonal, all these things should be an integral part of your diet for our tongue, for the taste sake. Of course, very, I mean, sometime or the other we can have the junk food, but we always have to think about all the other factors which are very, very important for your health. And you are in at such a stage where you can maintain your cognition with very finer changes in your lifestyle and your diet. And Indian diet is one of the best balanced diets in the whole world. So let us appreciate what we have, and our rich heritage is what I have to just add on to what Dr. Shubha has very rightly explained. Thank you so much, Dr. Shubha.
Go for exotic fruits, like most of them would like to have kiwis or dragon fruits, or I don't know, many other fruits.
Avocado.
They will
Yeah.
not help you actually. Maybe papaya, banana, whichever is growing near you, it will help you the most, and the vegetables also.
And what about the dry fruits? Because overuse of dry fruits is also not good. Parents think that, बहुत सारा अखरोट, काजू, बादाम खिलाया तो बस बच्चा मेरा एकदम 100%
That is also a very,
development.
I would say that is a wrong concept, because
Yeah.
the dry fruit grow in that area, say Kashmir or Himachal. So there, the people they face a lot of harsh winter conditions. So that's why nature has put those fruits there for them. So that will be beneficial for them, but not for the people maybe who are living in south or something like that. For them, coconut would be the best because
Right.
nature has grown coconut from for them.
Yeah, yeah, coconut and rice.
Yes,
Because you will see that they never get diabetic because they are eating so much of rice.
definitely. So nature is itself is helping us so much by growing things which are beneficial for us. So
Yes.
we try to take those things only rather
Yeah.
than going for exotic things.
Yes.
Thank you so much, ma'am. Actually, it was so interesting, even for our youngsters and all the participants. And the message which, as ma'am said, you have conveyed is a takeaway. I mean, we must actually practice this into a daily lifestyle. Thank you so much for your beautiful deliberation and your precious presence, ma'am. Thank you.
Kulkarni sir, would you like to add something?
I
Would
just
like to hear your views on this?
Sure.
no, am I audible?
Yes, you
sir.
are.
Yes, you are.
I just wanted to, yesterday I was watching Kaun Banega Crorepati. There was a
Yes.
boy who is a student of Sagar University.
Yes, yes.
He's a 19-year-old and his father is a watchman there, Chowkidar.
Yeah,
He doesn't eat akrod, he doesn't eat badam.
exactly.
All he does is keeps his brain active.
Yes,
He is 24/7, he sits in the library and reads. What is more important, keep your neuron active.
yes.
That's what I wanted to say.
Very,
Because
very
all
important
this
message.
akrod, badam, and all dry fruits and seasonal foods and all we are talking, we are addressing only 0.1% of the public.
Yes.
The rest,
Don't
99.99,
have access.
they cannot afford to buy any
Right.
of it. But
Yes.
when it was amazing that boy was knowing from
Yes,
Upanishad
yes.
to just most modern
Yes.
thing.
Very, very interesting session, yesterday's session. Yes.
Thank you.
Thank you so much, sir. Thank you. That was very, very significant message that you have given to all of us.
Because from this platform, if you tell the boys eat akrod, eat badam, we are perhaps misleading them.
Yes, right, right.
Thank you.
So much, sir, for your inputs, because they actually mean a lot, and also they would have conveyed a message to our youth and youngsters out there. Thank you, ma'am. Thank you for your precious time, for your presence and deliberations. Thank you once again. Thank you and we are looking forward to see you physically at Amity whenever we
Yes.
hold a.
We will take the next opportunity to invite her to our campus.
Sure, ma'am.
Definitely. Thank you so much, Dr. Shubha, for your very, very insightful talk. Thank you.
Thank you, ma'am. Thank you so much.
Thank you, ma'am.
Can I leave now?
Yeah. We are about to end the session now. Yeah.
Okay. Thank you so much.
Thank you, ma'am.
Thank you, Dr. Lucy. Thank you, Pranati. Thank you, Dr. Rahul.
Thank you.
Dear participants, we will be parting away for lunch. But before that, please let me announce and take note of it that the virtual oral presentation starts sharp 1 o'clock. And it has been divided into 4 tracks. Track A, pharmaceutics. Track B, pharmaceutical chemistry. Track C, pharmacology. Track D, pharmacognosy. The information regarding joining the MS team groups would have been sent to you on your WhatsApp group. Please keep a track of the message on the WhatsApp group. It would be nice if you join 5 to 10 minutes earlier in time so that you don't lag behind and we can be in time. And we'll be meeting again back on the Zoom platform at around 4 o'clock.
I would just like to add the track D. Track D is pharmacognosy and biotechnology. Please make a note that there are few abstracts which came from biotechnology, which are included in the track of pharmacognosy. So track D is pharmacognosy and biotechnology. Please make a note of this. And just to remind all of you, all participants of the oral session, please only and only introduce yourself without telling the names of any other co-authors, your guides, or please do not mention about the institute to which you belong. We are maintaining complete anonymity about these aspects. The presenting author will tell their name only. Nothing else should be there on the slide, nor while introducing yourself, you should be talking about any of these things, so that an unbiased evaluation can be done. All the best to all the presenters of the oral session. We are excited to listen to your research findings. I personally will be attending all the sessions and will be circulating in all MS Teams to listen to our budding researchers. And we are back here at 4 o'clock sharp, all the participants, for the valedictory function, where we will be announcing the results and the winners and the runners. So I request all the participants, don't think that, oh, my presentation did not go well, what is the point of attending it? Please come to appreciate others also and yourself. That's all from my side. Thank you so much. And please join sharp at 1 o'clock at the respective MS teams.
We break for lunch and we'll be joining on the same platform at 4 o'clock sharp. 4 o'clock. All the best, everyone who is participating.